the recording now. So welcome. Thank you for coming. This is the second event in our new research initiative, Finding Ecologies, at London Metropolitan University. My name's Trevor Norris. I'm the course leader for creative writing and English literature and part of the Finding Ecologies research group. This is the last session that we'll host before the summer recess, but we'll have monthly sessions starting up again from October next year. So if you have found us via Eventbrite, please follow us and come along to our next events. These are cross-disciplinary discussions that are concerning ecology, and this evening's event addresses the intersecting causes of poor mental and physical health. We'll consider policy recommendations and practical projects around the creation of accessible environments where people can flourish, and acknowledge the evidence-based approaches that can improve mental and physical health. Our guests this evening are Professor Kevin Fenton, who is the London Regional Director of Public Health England and the Regional Director of Public Health NHS London. Professor Fenton has worked in a variety of public health roles across government and academia in the UK and internationally. He became London's PHE Regional Director of Public Health and NHS in April 2020. He's the statutory public health advisor to the Mayor of London and provides leadership across London for health, prevention of ill health, health protection and reduction of health inequalities. Kevin was previously PHE's National Director for Health and Wellbeing, leading national prevention programmes including screening for cancer, NHS health checks, obesity, mental health, e-cigarettes and tobacco harm reduction, HIV, sexual and reproductive health. In spring 2020, Kevin oversaw the National PHE review of disparities in risks and outcomes of COVID-19, which included an epidemiological investigation, rapid review of the published literature, and an extensive stakeholder engagement with Black, Asian, and minority ethnic communities, professionals, faith, and system leaders. The review led to 7 key recommendations, which have shaped a more equitable COVID-19 pandemic response nationally and locally. It's now a year since the report was published, and there are a series of events that are happening around this month. I'm just going to put a hashtag into the chat, and you can follow the discussions around this on Twitter if you have an account. There is an event happening tomorrow, Tuesday, 22nd of June, 4:30 to 6:30, which reviews the report a year later. I'm just going to put the link for that in the chat as well. I want to introduce our second guest. We're delighted to be joined by Andrea Wright. Andrea is a chartered physiotherapist, somatic educator, and is the founder of the Black Swan Wellness to Work initiative for Black residents and carers in the London Borough of Lambeth who are living with long-term mental health conditions and chronic pain. Addressing the health inequalities that affect Black people in Lambeth, the project builds confidence, develops communication skills, helps people gain advice from employment experts, and manage emotions at work. And I just want to acknowledge a third guest who unfortunately couldn't make it this evening, Dr. Robin Mazumdar, and a little later on at the end of the session, I'll put some links where you can follow our guests and find out a little bit more about their work and research. So I'm going to introduce the session very briefly, so we've got another 5 minutes. A seminar on ecology might seem like an unusual place to have a discussion about public and mental health. A lot of eco-criticism and eco-philosophy happens in the humanities. So partly this evening's discussion is for the pleasure of a cross-disciplinary discussion to inform us and to give us an ethical sense of what's happening in other areas of policy, practice, and research. But there is another more fundamental reason for holding this discussion. As Sir Simon Stevens, the Chief Executive of NHS England, says, the climate emergency is a health emergency. Additionally, ecology is about care for flourishing and care for relatedness. In last month's session, we talked about the ecology of our feelings in relation to our dysregulated ability to read our own bodies and the practices we might adopt in the contemplation of our bodies and minds, the crafting of our attention, and of our artistic and aesthetic practices in relation to well-being. Today, we extend our discussion into public and mental health and a broader ecology of care. In this preamble, I want to seed and repeat a few themes, which we'll come back to at various points over the course of the discussion. How can public and mental health policy support and address the intersections of exclusion in people's lives? What are some practical, accessible and ethical steps we can take towards flourishing and finding community with others? How can we start to help ourselves and others manage emotional and physical ill health and distress? And how can we create environments in which we and others can flourish? When we hold up the image of ecological breakdown, we want to encourage everyone to participate in activism for change. Very often this is presented in a kind of maintenance and preservation model. Let's preserve and maintain what we have. But if our experience is one of racism, exclusion, and social, emotional, and physical distress, then why would we want to maintain and preserve things as they are? The PHE Beyond the Data report into COVID inequalities makes these essentially ecological points. We need clear, visible, and tangible actions at scale. We need fast, sustainable change, which is large scale and transformative. We need change to structural and societal environments, homes, neighbourhoods, workplaces. And we have a legal duty and moral responsibility to reduce inequalities. If ecology is concerned for breakdown in living systems, then there is breakdown all around us. Ecology is about creating the conditions for interrelated flourishing and solidarity in our lives. Structural racism and social exclusion are inseparable from the ecological domain. I want to draw a connection to our discussion last month, which concerns ecology without moralism. The space in which we try to address health inequalities is often freighted with angry moralism. When we need support, we're often coming from places of compounded inequity and great emotional distress. In public and mental health terms, a moralizing approach of there's something wrong with you for not being a better person doesn't work. And yet this is very often the dynamic of the ecological space. It's the end of the world, you're a terrible person, you need to change. My particular ecological interest is in finding a space for change that avoids shame structures, avoids respectability politics, which silences voices that are seen as troublesome, and which helps stop the impulse towards quietism, that is, turning away because things seem too complex to address. So there are three fundamental principles in ecological activism. They're undoing shame, speaking out, and organising for change. And I think that over the course of this evening's discussion, we'll address all those things in relation to public and mental health. These are essential ecological concerns, but they sit on top of historically urgent needs for transformation in the conditions of people's lives. Again, Kevin's PhD report specifically targets the need to tackle workplace bullying, racism, and discrimination to create environments that allow people to express and address concerns about risk. And I think this is a really important point, which has everything to do with an ecology of care. How do we create environments that allow people to express and address concerns about risk? So some last general prompts for our guests as a way into the discussion. And I invite Kevin to speak first, followed by Andrea. And please take any aspect of this introduction and these questions in whatever direction you wish. And these are the questions before we come into the next part of the discussion. What are the simplest, most easily scalable evidence-based practices for reducing risk and introducing flourishing and care where they're in decline? What do we know is effective in terms of potential and has the greatest reach in terms of practicability, public funding, economies of scale, and so on? What helps to resensitize people to the way that they've ceased to flourish in relation to themselves, others, and their worlds? I invite Professor Fenton to speak first.
Thank you very much, Trevor, and good evening, everyone. It's a real pleasure to be here, actually, this evening, in part because it feels as if this is a welcome break from the COVID-19 pandemic. As you heard from the introduction this afternoon, I'm London's Public Health Director, and for the past 18 months, I've been nearly 100% occupied on taking the city through now the two waves of the pandemic that we've had, and now as we prepare to move to the final milestone in the roadmap to unlocking our society, we're scaling up our vaccination program, we are engaging and mobilizing Londoners, but at the same time we have been working throughout the year to critically assess how we protect the most vulnerable in our city, how we advocate for and articulate the needs of those communities and of all Londoners in ways that are meaningful and understandable to policymakers. And given the inequalities that have been laid bare by the pandemic, how do we work both as the epidemic is unfolding, but as we plan for recovery and building back better and fairer? How do we do this through the lens of equity? So, as you said, Trevor, we don't go back to our normalcy, which is one that ingrains past behaviors, cultures, and outcomes that we had before the pandemic, but that together with communities, with individuals who perhaps were not engaged and not mobilized before the pandemic, that we'll be able to articulate a different, better, and fairer future for citizens and for our city. I'm also pleased that we're having this conversation this evening because as a public health physician, my work, by necessity, goes beyond the individual. It goes beyond the individual determinants of health. And as a public health doctor, I'm very much aware that good health, while having high quality access to high quality healthcare is necessary, it is not sufficient to create a flourishing individual or a flourishing community. But in fact, wider social and structural determinants, many of which you've already mentioned, Trevor, are critical to ensure that we have individuals for whom well-being is at a core of who they are, and what we all as a society strive towards. A future and a populace in which those wider determinants of health are equally addressed when it comes to improving health and well-being outcomes, as we do for ensuring a strong and robust NHS. By that I mean involving and working with partners outside of health. By that I mean ensuring that we're focusing on factors such as a great education, access to good housing, safe streets, communities which are connected, fantastic jobs which take care of the work environment and of their workers, and thinking about policies which are created which allow individuals and communities to thrive. So as the course of the evening progresses, I'm looking forward to the discussion. And I think I want to just to center where I'm coming from, my unique perspective as a physician working in public health in the midst of this pandemic, thinking about the future, but also firmly planted on the needs of our city and our citizens at this time. Thanks, Trevor.
Thank you, Kevin. And I now invite Andrea to make an opening statement, and after that we'll come into a discussion between the three of us.
Hi, good evening. Thank you, Trevor, and thank you, Professor Kevin Fenton, for this invitation and this conversation. I'm really honoured to be here and amongst each of you to discuss this important topic. My background, as Trevor kindly introduced, is working as a practitioner and founder for Wellness to Work initiative, working with Lambeth residents who have mental health and chronic back pain and their carers. One of the things that I feel is really important when I've been topic is to understand and peel back what I understand as being care. And I think one of the ways that I've approached it is to understand how we've been dissociated from caring and the practice of caring. And part of that has been informed by the way we have been socialized to invalidate our feelings and to invalidate what we understand as our felt sense and emotions, and our dissociation from our feelings, our bodies, a separation from our mind and our bodies, and therefore separation from body and the world, I think is fundamental to this conversation. So when I think about care and I think about flourishing, and I think then about what we understand for the conditions of flourishing, we need a multiplicity of agents and ideas and are items in the room for things to flourish, and not just any one position. So for me, the remit, particularly with my work, is to think about what are the conditions that allow us to flourish. And one of those things is thinking about space, and how might we offer space to individuals in our relationships, in our physical demographic areas, for this multiplicity of ideas, for this multiplicity of positions and choices. So I think, in particular, when I think about Black mental health, and we think about the statistics that certainly are are clear in relation to the Black experience in integrating with mental health services. We have poor access, we have poor experiences, and we have poor outcomes. And I think part of that is about creating space for Black individuals, and those who are marginalized then in terms of wider axes of oppression, to be able to see themselves, and to have a space that they can see themselves, and have a space that they can be seen, to have a space that they can have choices, that they may be able then to choose and create some autonomy, and also to have the space to feel. One of the things that is clear, certainly in terms of my experience, and those people who are marginalized and racialized Black, is the fact that we haven't been, our feelings and our subjectivities haven't been validated. And I think this is something that's really important to think about, the ways in which we reclaim validation of our experience, of those microaggressions, of the harm that has been impacted. And so this idea of being able to give space to marginalized people to begin to feel their bodies again, to embody their emotions, to make sense of their emotions, and to have that validated and to have that name, is something that's really important to be able to, as part of the conditions that we are hoping to create in terms of flourishing. So I'm really excited to share more ideas in this vein, and yeah, I'm looking forward to the conversation.
Thank you, Andrea. And there's something very important here about being seen and being heard at the level of the kind of services that can be provided, not just by the National Health, but in terms of community support organisations as well. And Kevin, in your report, you made 7 recommendations about how these inequalities should be addressed. And for me, what's interesting about this discussion is that you're dealing with large-scale processes of change, and Andrea is looking at very local and small-scale processes of change, which are obviously hugely important in that greater picture. It's been a year since the report has been published. Where do you think we are in terms of addressing this important issue of stakeholders being seen and being heard?
So first of all, I'd like to just acknowledge what Andrea said, because I think so much of what you heard about the personal, the individual, what happens in place, is in a sense what I need to consider as a policymaker and somebody who's working at a much wider level in terms of regional health. Because to do anything at scale means that we need to understand and value and support all the things that Andrea has said if you truly are in the business of improving health outcomes. And I want to begin by acknowledging that, because often we see these domains of deliverance somewhat differently, and not recognizing that actually, for me to be an effective policy developer or to develop programs, I need to hear from Andrea and what Andrea is learning. And I need to value what Andrea is saying as somebody working in the community in order to develop culturally competent interventions that can make a difference in health. Too often, we see where programs are developed from perceived evidence with stakeholders who may not know or understand what really is happening at the grassroots. And you end up with programs which obviously don't work. And that's certainly one of the challenges that we have. So the report last year, as you said, had 7 key recommendations. And I should say that we selected 7 recommendations for the report because we're emerging from the first wave of the pandemic. And it was absolutely necessary that we moved quickly to intervene and focus on a few interventions which could be achieved at scale, so that we could mitigate the risk of a second wave of the pandemic and see the similar outcomes that we saw, which were a disproportionate impact of the epidemic on a variety of population subgroups, including people of older age, people living in more deprived communities, Black, Asian, and minority ethnic communities, to name a few. The recommendations focused on a range of issues, but at their core, they were in 4 areas: better data, better research, more culturally competent interventions, better accountability, and as we move into the space of recovery, to ensure that we had equity, the lens of health equity at the forefront of our minds, and not as an afterthought as we did our recovery programs. And Trevor, I would say, if I reflected on the past year and a half, the conversations that we're having today are fundamentally different to where we were in spring of last year. Number one, inequalities, social justice issues are at the forefront of every policymaker within the NHS, local government, working in the Mayor's office, in the Department of Health and Social Care. They may not be termed social justice, but people are absolutely clear that they have seen wave after wave who is disproportionately affected by COVID and what is needed in terms of supporting community cohesion, community connectivity, financial stability, overcrowded housing, working with key workers, or working with and engaging with communities of diverse languages and backgrounds as fundamental to what we need to do in COVID. Second, because the work on recovery is happening concurrently with the response to the pandemic, as we're commissioning programs, whether for mental health, physical health, community housing, workplace interventions, or economic interventions, the desire to ensure that we are joining up, building upon all the relationships and partnerships we've developed over the past year to ensure that we're tackling inequalities up front is certainly part of the discourse that I'm seeing now that I hadn't seen before. For me to hear business leaders in London speak about dealing with people who may not be engaged, or ensuring that they're working with communities whose voices had hitherto not been at the table, is certainly a sign of a potential legacy of this pandemic. And finally, in terms of where we are with the recommendations of the report, I think the challenge is on all of us, right? So I was deliberate in the recommendations that the recommendations weren't to government, but they were to us as a society, because it meant that every layer of our society, every bit, should ask ourselves, what have we done? What have we learned? And now that we know better, how are we doing better in our spheres of influence and our spheres of domain, of action? And I think that's a key part of the lessons from the last year for me.
Thank you, Kevin. And I'm just going to briefly drop into the chat for guests a number of links that people can follow to find both. There's about 6 or 7 links in there. They can find more information about that. But in particular, you can find the PHE report in one of those links, and you can find the 7 recommendations. There's also an incredibly useful appendix at the end of the report that shows the extraordinary wealth of information that can be called on to try to build these organic, collaborative relationships between people. One of the things that I think is really interesting in the report is this urgency about building culturally competent interventions, as you've just mentioned, and maybe bring Andrea into the discussion at this point to talk about her own project, the Black Swan Wellness to Work Initiative, as an example of a culturally competent project that seeks to transform people's physical and mental health.
Thank you. Thank you, Kevin. That was really helpful to bring in this piece about citizenship and our citizen requirements, not just for policymakers, but each of us as citizens to really have these learned examples at the forefront of our minds and what we now know and how we can move forward in a more equitable way. I would like to, I think, really use the term cultural safety in terms of my project, perhaps rather than competency as a set of tools, but how, again, talking about environments, what is it that my project and maybe other projects that are similar are providing this cohort of people. And I think one of the things that is important for me is to, as I'm naming it, is to recontextualize the language and the narrative around health outcomes and poorer mental health outcomes and physical health outcomes. That is to say, the experience of Black individuals who have mental health challenges or physical challenges isn't just the sole responsibility only of their own individual behaviors and attitudes, but it is also as a function of the hostile environment that they may be part of and experiencing racism on a day-to-day basis, which we understand and know has real teeth and has real impacts on somebody's mental and physical well-being. So the project really helps to reframe, if you will, and give another angle and widen the narrative as how individuals who have these challenges may begin to make sense, in part, about their particular circumstance. And so for me, part of that material really is bringing in the evidence around how racism does impact our mental health and race-based stress, how that impacts on our physiology and our neurobiology as well, and how we can make sense of that, which is where the piece about, or the piece that I bring in is about using somatic practices and embodiment practices that help us to understand the neurobiology of how we interpret information, how we use interoception to understand our emotions, and how we might use that information to then language and use clear language in the workplace to be able to communicate ways that do not yet perpetuate harm. So I think safety and understanding and naming then this piece about not invisibilizing the experience of Black people, but really creating visibility, naming the harm, which I think adds a space for safety. And again, I'm coming back to this piece about space.
Thank you, Andrea. And I'm just also going to drop a few links into the chat for people, and they can follow up, follow you on Twitter to find out more about your project. I want to come to this question of how we build data Sarada has asked a question in the space, and it was one of the recommendations in the report about having more robust data collection, being able to have a much greater sense of inequalities and structural exclusion, the way that racism affects people's ability and confidence to access health systems. But at the same time, there's a problem which is the one that Sarada identifies. And the question is this: how can transformation of the space or region, and I presume we mean here the space in which people can access public mental health services, how can that occur when the data is inconclusive and isn't being adequately collected to reflect the health challenges of people of colour who are systemically traumatised by hostile mental and physical health services? I mean, in a sense, this is a tricky question, isn't it? How do we build trust in such a way that allows people to access the services that they need? And perhaps I can ask Kevin to respond to this first of all.
Thanks for that question, and you're absolutely right that a key part of understanding and characterizing a problem, in order to address it, you need to have good and better data to do so, and that was why that was the first recommendation in the report. Now, there are different levels of data which are required for us to improve practice. If we are in the business of improving access and outcomes and the quality of experience that people have, which is what I think we should be doing, that sort of triple aim. We should be looking at experience, access, and outcomes. It means that you should be looking at your data to ensure that you're capturing the key indicators that can help you to get a sense of all of this. And for too long, we have remained in the space of, can we characterize activity within services, and then let's add to that sort of a racial and ethnic categorization in order to look at the variation by activity, by ethnic groups. But increasingly, that isn't good enough. And there's a better move and a stronger move now to look at monitoring outcomes, both clinical outcomes, but also social outcomes, to begin thinking about well-being and how you measure at the individual and the community level the well-being within which that person sits and within which that person and through that person will operate. And finally, to be able to capture, working with patients, working with communities, indicators that can help them to understand experiences. You know, when I did the research last year on COVID and inequalities, I had the privilege of engaging with more than 4,000 people from across England to understand lived experiences, to understand from policymakers, providers, communities, why we were seeing these differences in COVID's manifestation and what could be done about it. And what struck me throughout the interviews was when you spoke to communities, the stories of a lack of trust, a lack of a mistrust, negative experiences of using health services, and how they translated into people not wanting to appear for testing, people not wanting to go into the hospital because of concerns about quality of care. And those experiences have played through the entire pandemic. So we've seen people not wanting to take the vaccine because of lack of trust, because of a concern that you have never engaged us before. Why are you engaging us now on the vaccine? So these issues in terms of the data must be quantitative. They must be qualitative. They must focus on experience, access, outcomes. They must include people's lived experiences and their stories. And policymakers have to use the data of those lived experiences in ways that can help us to truly change our practice. So I think it's not a, people often go to, yes, let's collect more ethnicity data, thinking that that's the end of the story. It isn't. It really is only the beginning of what we need to do to get a more holistic approach to addressing these issues as well.
Thank you, Kevin. This is really interesting, and not least because it's coming close to my own discipline, which is storytelling, having a persuasive story that can involve people, in which people see themselves properly represented. I want to invite Andrea to talk a little bit about her own practice and how at this local level working one-to-one with groups, you can facilitate that experience of people having the opportunity to tell their own story. And here I'm asking for the basic practice of care that opens up this space in which people can be heard.
Yeah, I think really interesting, the idea about data in its broadest terms. I think our subjectivities are often understood as not being validated, or not having being valid data, as it were. You know, what we feel, our emotions. Sorry, can you hear me?
Yes.
Look, sorry. The validity of our subjectivities is often being relegated as not being valid. And I think the spaces that, or the spaces that I'm creating, is really to foreground people's experience and their subjectivities and their stories, so that that is validate, that is part of the data that we take for as a given, as given. And I think the ways in which I do that, I've touched on it before, is really inviting people to bring their sensing bodies, explore their inner response to the world, explore their inner response to relationship, and really foregrounding that as something that we are interested in and curious about. So on a really very local level, and I think this is a piece that really, I think, is really important. Kevin is speaking at a very macro level. The question is, how do we get to practice care at a very accessible level? And I think that is something that we do within ourselves, and part of these practices, these embodiment practices, that really center our subjectivities and our stories and our feelings that touch into our bodies, is one way we can really get to the granular detail of how do we practice caring for what we don't yet see, caring for what isn't seen to us. And what isn't seen to us often is the parts of ourselves that we don't want to see, that are suppressed, or that are repressed, or that are relegated. And if we use this term, excluded. So how might we bring and shine a light on those parts of us within us that are excluded, and begin to care for those pieces that may bring up shame, that may bring up guilt, that may bring up sadness, that may bring up a number of emotions that we are not socialized to perhaps claim, own, or express. And I think the way that we can do that in terms of scaling up care is a self-practice of caring for what is within us, and a self-practice then that we can do interrelationally.
Thank you.
Trevor,
Yes, go on, Kevin, please.
sorry, can I just quickly respond to Andrea, because she said something that really struck me. Andrea, a number of the things that you said there, I wonder if they apply to organizations as well as individuals as well. Because it is in the looking internally within organizations, it is in confronting the things which are difficult when we think about workplace environment, how we treat key workers, as well as people who are at the top of the executive chain. The way we create environments and are able to uncover in a safe way the realities of working within organizations, that you can actually begin to change, I think, workplace well-being, the experiences, and undoubtedly the quality of the work that we do, because we have that journey of discovery, of honesty, of listening to ourselves, as a key part of what organizations should do as well. And I say this, Andrew, because a big part of the work that we're doing in London is not viewing inequalities as something that organizations do to others, but that they do to themselves. that process of internal reflection, looking at structural and systemic racism, looking at stigma, discrimination, and bullying within organizations, and empowering people to say the things that often organizations don't want to hear, becomes a key part of that organization doing better for their communities, of that organization truly valuing tackling inequalities. And I hope will be a legacy of what we do. So something in what you said in terms of what we all need to do individually to get to a better place, that honesty, I think that also there's a metaphor there for what organizations need to do as well. So I just wanted to thank you for that really strongly.
And thank you, Kevin, and thank you both. Guests, we have about 10 minutes left before we end the session at 7 o'clock. So please do add any questions in the chat. If you would like Kevin or Andrea to respond to anything that you would like to address. I want to come to this point that you have just both articulated, which is about the need to really interrogate where we are across all scales. Our interpersonal relationships, our institutional relationships, the hierarchies we work within, the context that people come from within the institutional interactions that we might meet them within. Maybe this is a chance to look forward to the future and think about the transformations that are going to happen within the ecology of care inside the NHS, and possibly say something about the integrated care systems that are going to be a feature of the NHS from 2022. We talk about the optimistic need to integrate data, to integrate stories, these local granular experiences of being heard and seen, flourishing relationships to ourselves and in the immediate communities we're a part of, and then building this in across scale into these large-scale new structures like the ICS. Do we have reason to be optimistic about this joining of resources, data, forms of collaboration? One thing that I think is really nice about the way that the ICS is being spoken about is that it's collaboration rather than competition as a principle, which is an essentially ecological principle. I wonder if, Kevin, you could tell us a little bit about your feeling about the ICS.
Sure. So, you know, I share your optimism as well in terms of viewing this as another structural intervention that will enable us to hopefully behave differently, organize ourselves differently, and achieve different and better outcomes. But we shouldn't be lazy in thinking that a structural change is going to be necessary and sufficient to get the cultural shift that we need to truly improve outcomes. And I think hand in glove with this transformation, this organizational change, has to be work on, as you've mentioned, Trevor, data, so that we get better at characterizing problems and assessing our performance and tracking our progress. It has to also transform leadership, so that at every level of that organization, you embed the collaborative behaviors as well as the outcomes-focused behaviors that you'd like to see. Otherwise, there's a real risk that the organization reverts to type and focuses on activity, buds passing through the organization, rather than truly changing and improving the health and well-being of the people that we're serving. Third, it requires us to really think beyond the individual to population health, and ways in which the NHS works with local government, with the voluntary and faith sector, to really think about improving health. And that becomes a defining outcome for that organization. And finally, I think the ICSs will really have a lot of work to do to change culture, because it is within that culture of the people working within that organization will determine how members of their employees, the people who they're commissioning, how they actually engage with members of the public, and how members of the public feel that this new structure is truly different. Because if people's feeling and their experience of the GP, of calling 111, of going into the local hospital or getting social care doesn't fundamentally change, then I would argue, has this transformation been effective? Has it managed to do some of the things that we know our health and care systems need to do to be functional and effective and sustainable in the 21st century.
Thank you. We have 5 more minutes only, and time's gone by incredibly quickly. I have a question from Nick in the chat, and it's this. The point highlighted by Andrea about the need to identify and develop spaces of inclusivity in cities to address mental well-being touches on a more fundamental issue about the environmental crisis. This concerns the concurrency between the crisis of the human condition today and our increasing estrangement from nature as a result of our disconnection from the rhythms of the natural order. There's growing awareness amongst environmentalists, philosophers and psychologists that addressing the former is conditional upon addressing the latter. That unless we fundamentally rethink the civic lives of our cities, we're forever constrained by the hope of technological solutions to the crisis we face. Hence, reorienting ourselves to the natural world through education, environmental engagement provides the foundations for restoring collective space in our cities. And I just want to recognise that, again, the absence of our guest, Dr. Robin Wazunda, whose research specialism this is, how do we create equitable spaces for flourishing, which people can access in ways that are culturally safe, coming back to a term we've used earlier on. I'm just going to drop Robin's research into the chat for people to follow up should they wish. Andrew, this question of reading our bodies, feeling safe, you mentioned interoception. It was a theme that we touched on in the first talk. I wonder if you wanted to say something about this, how we might reconnect this question of disconnection from the natural order of our being, our resting sense of calm. How might we, in your practice, connect with this?
Yeah, thank you. I want to also just connect this to the last piece about integrated care systems and what Kevin had spoke about in terms of the experience and the felt experience of individuals who access services throughout the healthcare system, if that changes. And I think one of the things that came to my mind and this question also is speaking about space, literal spaces that we need to flourish. And I think about the statistics for those people in Lambeth, where those in terms of occupancy, they 70% have limited access to green spaces. So thinking about their I guess potential for flourishing, but I'm also now thinking about the space that I as an individual can afford as a practitioner, an individual who comes into my therapy space. If I can just allow and a lot more time, space literally enables not just one view, but a multiplicity of views. And an individual who comes into my space, if they have a multiplicity of views, space, time, they perhaps have choice. And having choice is also one way in which we can have more agency in terms of how we may make decisions, how we may put our own ideas into the frame, and really beginning me as a practitioner, how do I decenter my ideologies? How do I decenter my ways of thinking? And so I give space, literally time, listening to the individual who's coming to work with me, and to be able to really hold with non-judgment, with compassion, the space for the individual to then see themselves. And this piece about witness, if I'm affording them space to see themselves, and I create myself as a compassionate, non-judgmental witness, we have an internal seeing, we have an external seeing, an external validation, an internal validation. And I think this is very, very powerful in terms of beginning to create conditions for flourishing. And then speaking about, well, natural spaces that we have that enable us to connect to the wider natural world.
Thank you. We are 1 minute before 7 o'clock. We have a couple more comments in the chat, which I'm afraid we won't be able to address. But once again, I'm going to put a link to the PHE report on inequalities. That's there in the bottom of the chat. And it's a really excellent report. I really recommend that people have a look at it, including the kind of conversations, once again, that are happening around this 1 year later. I'm going to put one more link in the chat, which is from the NHS Race and Health Observatory, which has followed up the report's recommendations and is engaging with that as we speak. There's a really excellent recent report from the King's Fund that is just available on the website and published in the last couple of days. It's 7 o'clock. Once again, thank you to our guests, Professor Kevin Fenton and Andrea Wright, for this wonderful discussion about ecology of care. This is our last session before the summer recess. We hope you come back and join us after the break. Thank you to our guests. Thank you for people for attending. Thank you.
Thank you.
Thank you, Trevor. Thank you, Kevin.
Thanks,
Thank you
Andrew.
very much.
Thank you very much. Thank you. Take care. Bye.